Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. At the end of today's presentation, we will conduct a question-and-answer session. To ask a question, please press star 1. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the meeting over to Irene Ahir. You may begin.
Thank you. Hello, I am Irene Ahir of CDRH's Office of Communication and Education. Welcome to the FDA's 48th in a series of virtual town hall meetings to help answer technical questions about the development and validation of tests for SARS-CoV-2 during the public health emergency. Today, Toby Lowe, Associate Director of the Office of In Vitro Diagnostics and Radiological Health, and Timothy Stenzel, Director of the Office of In Vitro Diagnostics and Radiological Health in the Office of Product Evaluation and Quality, both from CDRH, will provide a brief update. Following opening remarks, we will open the line for your questions related to the development and validation of tests for SARS-CoV-2. Please remember that during this town hall, we are not able to respond to questions about specific submissions that might be under review. Now, I give you Toby.
Thanks, Irene. Thanks, everyone, for joining us again. As we started, we mentioned last week, we started taking questions ahead of time by email. So I will give an update on those as well as a follow-up on a question or two from last week. So first, I want to touch on a question that came in during the call last week that we then followed up with over some emails and wanted to clarify for everyone on the call. This is regarding the use of pooling and in what situations that is considered screening versus surveillance. We have got a number of questions about surveillance versus screening, and it is a tricky topic. So we did clarify with this specific situation that was asking about collecting a 10 swab pool where all the swabs are placed into the same transport tube with media, with the assumption that you plan to recollect specimens from each of those individuals if the pool is positive, where the intent is to determine each individual's COVID-19 status or SARS-CoV-2 positive or negative status, such that that individual could or would take action based on that result. So in that case, the testing protocol that was proposed appears to be screening, since it is intended for individual action. Along those same lines, we received over email one of the questions related to use of an EUA test for surveillance purposes. And what I'd like to ask is that anyone who is interested in or has specific questions about surveillance, please send those in by email. We receive a lot of questions about testing proposals that are actually screening, not surveillance. And so we want to make sure that we have all of the pertinent details before we give you feedback so that we can make sure that we provide the appropriate feedback for your specific situation. So let me start walking through the rest of the questions here that we received. We received some questions about supporting a screening claim when there's already an EUA for the qualitative detection of SARS-CoV-2, and this is related to the supplemental EUA template that was issued last week. So our recommendations generally for validating asymptomatic screening are included in the main molecular EUA template if you're interested in an individual screening claim. If you're interested in the serial screening claim as outlined in the supplemental EUA template, you likely don't need any additional pre-authorization data. In that case, we recommend that you submit a supplemental EUA request with your requested indication, including the serial testing interval and your proposed post-authorization validation study. Regarding serial testing, we also received a question about antigen tests and whether the serial testing approach would be acceptable if the antigen assay does not reach the 80% sensitivity in symptomatic individuals. We do discuss in the antigen template for test developers that strategies for serial testing with less sensitive tests, such as a PPA less than 80%, may be able to support authorization. But in those cases, we would expect the clinical evaluation in an asymptomatic population to be completed prior to authorization of a screening claim. The shift of the validation to post-authorization discussed in the supplemental template is not applicable for tests with sensitivity below 80% in symptomatic subjects.
And I would just add that the pathway for those suspected of COVID for an antigen test is still available for those that have a single test PPA of less than 80%. If you want to use serial testing in the symptomatic population as well, so that pathway still remains open, as described in the Hill piece we wrote back in September. Thanks, Toby.
Great, thanks for adding that, Tim. Next, we received a question about the process for submitting data to OIR for an EUA. So to clarify, we do have the EUA templates for serology, antigen, and molecular tests up on our website, and ask that you submit your EUA request to cdrh-EUA-templates at fda.hhs.gov. Those templates generally reflect our current thinking on the data and information that developers should submit to facilitate the EUA review process. Once we receive that, we review your EUA request and determine whether it is sufficient to support an EUA authorization. And then at that point, if we do believe it's sufficient, we would authorize the test, send the sponsor a letter of authorization, and add that test to the FDA webpage. We received a question about an OTC antigen test and asking to confirm that the data should show a minimum of 80% agreement with a predicate to be considered for approval for an EUA. So just to clarify some terminology there, for an EUA review, it is different than a 510K review. So it's not, an EUA is not a substantial equivalence determination, so there's no predicate. But we do often ask for a comparator test to be used in your clinical evaluation. So I think that's likely what this question is referring to. And we do recommend for OTC tests in the antigen, the non-lab template, we do recommend a minimum of 90% PPA for OTC tests as compared to the comparator test. And in the new supplemental template issued last week, we recommend a minimum of 80% PPA for serial testing claims.
And those PPAs are in symptomatic individuals. And the comparator test can be the recently granted molecular test, and any subsequent ones coming in for full authorization could use that test. But then you can use other EUA authorized comparators as long as they're high sensitivity molecular tests with an extraction step. Thanks, Toby.
Thanks, Tim. And that leads perfectly into one of the next questions, which was actually about the Biofire de novo that was recently granted. So as I'm sure most people have seen, Biofire was issued a de novo for their expanded respiratory panel that includes SARS-CoV-2. And this question is asking whether their test is now the only one that can be used as a predicate for subsequent submissions by other manufacturers. So since Biofire was granted a de novo, they are currently the only legally marketed predicate for a 510K submission until subsequent tests are also cleared through the 510K pathway. So for future 510K submissions, Biofire is currently the predicate to use there. But for your comparator, for your clinical evaluation, you can use Biofire, but you also can use an EUA authorized, highly sensitive RT-PCR assay for the clinical evaluation, as well as for EUA requests. And we do recommend that if you intend to pursue the 510K pathway, that you submit a pre-submission to discuss your proposed validation strategies and your comparator methods, rather.
And I would just add, since we have not granted a serology test or an antigen test, that those initial applications would be through the de novo pathway.
Yes, great, thanks. And continuing on the Biofire path, we have a question about an EUA under review, an EUA request under review for a similar expanded respiratory panel with flu, RSV, and SARS-CoV-2, and whether they need to figure out how to perform clinical studies this year, even though there's the low influenza prevalence, in light of the Biofire de novo, or whether the EUAs would be able to remain in place. So I do want to clarify that the Biofire de novo did not impact any EUAs other than their own for that identical test, which was revoked concurrent to granting the de novo for the same test. Biofire's other EUAs, including their point of care test, as well as EUAs for other developers, were not impacted. We obviously can't anticipate when the public health emergency will end, but we are committed to helping ensure that the public has access to a wide variety of test options for COVID-19. And we do intend to continue to review EUAs to address the public health needs. Continuing on the influenza and RSV line of questions, we have a question asking whether FDA is open to the use of archived specimens to pursue clearance of an expanded respiratory panel to include flu A, B, RSV A and B, and SARS-CoV-2. So generally, to evaluate the clinical performance of your multi-analyte test, a prospective clinical study should be conducted. Considering the public health needs in the current emergency, a clinical performance study in support of your EUA request may be conducted at one site, testing archived positive and negative clinical samples with known specimen types. The pre-selection of archived positive samples should represent a range of viral load or CT values, including low positive samples near the assay's cutoff. And since this is typically for a device that has not been FDA cleared for the respiratory pathogens included in the test, and it's likely that the test would be used in patients with respiratory symptoms in lieu of an FDA cleared respiratory panel, we do intend to include a condition of authorization that you conduct a post-EUA, a post-authorization prospective clinical study that would include a minimum of 3 sample collection sites and 3 testing sites, prospectively enrolling patients with general respiratory symptoms.
And if someone's interested in pursuing a full authorization of an EUA panel, we would still allow some archive sample use. However, we would ask for that prospective clinical study for the conversion to a full authorization and collect as many positives as are feasible. We understand that some respiratory viruses, especially flu, are very low in circulation even during peak respiratory season during the pandemic. And so the recently authorized Biofire de novo in the special controls does speak to this use of archive samples if the prospective study demonstrates low prevalence of certain viruses. Thank you.
Thanks, Tim. The next set of questions that we received is regarding the difference between EUA requirements between prescription use lateral flow antigen tests and non-prescription use lateral flow antigen tests. So generally, the recommendations for analytical and clinical validation are included in the EUA templates. And we expect that the clinical evaluation be conducted in the appropriate setting, such as point of care or at home, depending on the proposed indication. If you're seeking an asymptomatic screening claim, you should validate in that population. Though, as we've discussed in the supplemental template issued last week, you may request a serial screening claim based only on symptomatic validation. Additionally, for tests intended to be performed by lay users, you should submit usability data. And for OTC tests, where the lay user will also receive and interpret the results themselves, we would expect user comprehension data. The question further asks if data from asymptomatic individuals for an OTC claim could be done post-authorization. So generally, for non-prescription tests, we do expect that they will include a claim for asymptomatic screening, since there would not be a healthcare provider involved to determine if the individual has symptoms or is otherwise suspected of COVID-19. And generally, we do expect to see that the asymptomatic validation pre-authorization. But in the case of serial screening, per the supplemental template, we will consider authorizing that claim with a post-authorization condition to establish performance with asymptomatic individuals when your PPA is at least 80% in symptomatic individuals. We received a question about high volume and low volume settings or tests for lateral flow tests. And we have discussed this previously, where we do prioritize review of EUA requests where authorization would significantly increase testing capacity, such as tests that reduce reliance on test supplies and high throughput, widely distributed tests to address public health needs. We can't, unfortunately, provide specific numbers of what we consider to be high or low volume or throughput, but if you need help determining whether your test would be considered high testing capacity, we recommend that you reach out through the EUA mailbox with information about the features of your test.
I would add that lateral flow devices are one-at-a-time devices, and if they're being performed in a high or moderately complex lab, they are not high throughput tests, and so their prime value in the pandemic is in the point of care or potentially the home setting. So that's where we focus our priority reviews for lateral flow devices.
Thanks, Tim. We received a question about over-the-counter test kits and whether or not they're required to report the results to public health authorities. And we do encourage developers of home tests to include mechanisms for reporting results to public health authorities. We don't intend to hold up authorizations of home tests that do not have this, but we have in some cases included the development of such a mechanism as a condition of authorization for home tests that we've authorized before that has been available.
Yeah, and that's after some period of time after authorization. And absolutely, we see the reporting of data from all types of tests as useful to managing this pandemic, and any method that can streamline the reporting of that would be helpful. And HHS and the administration have been working on pathways to do this, and they continue to make advances, and would refer you to them and their announcements on the availability of reporting features. Thank you.
Great. And then the last question that we'll go through from the pre-sent questions is regarding assay controls for home tests, and whether external or internal controls are needed for at-home tests. So we do generally believe that external controls are important for quality control and training, but we don't think that they're typically needed for at-home tests. However, we do recommend that at-home tests have an internal control to ensure that the test results are valid. And with that, I think we can turn it over to live questions.
Thank you. We will now begin the question and answer session. If you would like to ask a question, please press star 1. Please unmute your phone and record your first and last name clearly when prompted. Your name is required to introduce your question. To withdraw your question, you may press star 2. Once again, at this time, if you would like to ask a question, please press star 1. One moment, please, for our first question. Our first question is from Parvan. Your line is open.
Hi, thank you for doing this. I'm Parvan. I'm with Green Road Diagnostics. We've been added to the commercial manufacturer notification list in late December and been under high throughput EUA review since. However, this Monday, we received a mail from the FDA team saying we are no longer under active EUA review as we are not high throughput. We have a couple of questions, but just adding more color to what we're doing. Excuse me. Our test is a direct saliva RT-lamp assay with MRI detection, which allows for massive parallelization for ultra-high throughput. It does not require extraction, which greatly reduces total time from sample to answer. We chose 96 well plates as our base processing unit. The manual steps required are equivalent to manual handling with high throughput RT-PCR systems. To be classified as high throughput, there seems to be a guidance where 384 well plates are required instead of 96. There also seems to be a guidance for automation to be included directly in the EUA. Now coming to my questions. First one, where 96 well plates read simultaneously meet or exceed automated 384 well plates, what is the consideration for qualifying as high throughput? Second question. Sorry, go on, please.
No, go ahead. What's your second question?
Second question is whether throughput of the manual process meets or exceeds the throughput of the automated systems. Should automation be included in the EUA, or should a separate EUA be submitted?
So this is a very specific question for your specific technology. And we have invited all developers to send an email to the template's email address or through a pre-EUA process to address whether or not their specific test would meet our current threshold for priority review. And if you have been unable to get your question answered, please send another email to the template's email address and ask that Toby and Tim be copied, and we will respond as quickly as possible to you about your specific situation.
Thank you. We actually just did that. Just since we got the mail on Monday, we were not able to get in time to submit the question early on for this town hall. The one thing we want to clarify is because of the difference between 384 and 96 well plates. If we use 96 well plates, but if our throughput is meeting or exceeding, how would it be considered? That's something we were not clear on.
Yeah. So you have a very assay specific question here, and it's best handled offline and not on this call, so that we can understand the details of your test and see if it doesn't meet our threshold and give guidance for modifications you might be able to make. So your questions are very focused on your specific tests, and it's best handled offline as the leader of the call has suggested at the beginning of the call. So if we could please go to the next, and please make sure that Toby and I are included in your email correspondence on this, and we'll make sure that you get a response. All right, thank you. Let's please move on to the next caller.
Yes, our next question is from Kabumodi Venkat. Your line is open.
Good afternoon. Thanks for taking my call. I have a question related to the serology template that was put last week, March 17th. I'm looking at the clinical agreement study section of the template, and it is suggesting the section A, the comparator as the RT-PCR test. I think this RT-PCR test as a comparator was there early on, but now that we have so many EUA authorized serology tests available, is it possible to use EUA authorized serology test as a comparator rather than RT-PCR test? Is there any rationale in requiring only RT-PCR test as a comparator? Thank you.
Yeah, thanks for that question. We continue to believe that RT-PCR, high sensitivity molecular test with an extraction step, remains the best comparator for all comparisons, whether it be serology, antigen, or molecular. And the serology test can have a lower sensitivity and be authorized. So for now, we're continuing with our recommendation that molecular be the pathway. But as always, these are recommendations, and if you want to pursue something that's not recommended and get a preview on our thoughts about that validation, you can send a pre-EUA to the template's email address. Thank you.
Thank you.
Thank you. Our next question is from Elaine Allen. Your line is open.
Yes, hi. Thank you for your time that you give us every week. It's very much appreciated. My question concerns a comment made last week regarding clinicians ordering off-label testing to look at the response to vaccine. Last week, FDA stated that after investigations, it had turned out that the vaccine generated an antibody to the spike protein, but the serology test was directed towards the endpoint. So therefore, the serology test was not a good candidate to look at the vaccine response. My question is, would a serology assay that looks at the spike protein potentially be a candidate for a vaccine response?
So, I think this may be vaccine specific. And if a test wants to make a claim that they can detect a specific response, then a clinical study, should demonstrate that. So, clinicians, we don't object to clinicians ordering tests off-label. They do that fairly frequently. They prescribe drugs off-label. When they do that, they are taking more responsibility, obviously, for the use of that test or perhaps for that drug. And we're just wanted to make sure that they're aware that not every serology test that we've authorized can detect an immune response to every one of the vaccines. We haven't analyzed that. But clearly, if there's a mismatch, then that you would theoretically know that an N protein antigen test would not be positive if the patient has only received a spike protein vaccine. And again, we're open to submissions that at least want to clarify this, because as this goes forward and clinicians use serology tests in this manner, even though they're not authorized for this, we want to make sure that it's clear, that certain tests could potentially be used. So I'm not sure how we're going to do that, but we're open to what test developers want to do in that regard. And so it's probably best to come in with a pre-EUA with something that you'd like to do and suggest along with some sort of study design.
Okay, so it wasn't a sweeping comment that all serology tests were not candidates. It was just that particular issue or situation.
Yeah, it's a theoretical mismatch. But again, you can have a spike protein a vaccine, or not again, but I would say that you could have a spike protein vaccine that may not overlap entirely or completely or even at all, perhaps with a spike protein antigen test, depending on what's the antigen in the vaccine and what's the antigen in the serology test. So just because it's, I don't think we can make a blanket statement that a spike protein serology test, works for a given spike protein vaccine. We'd like to, if someone's going to make that claim, we'd like to look at data that supports that. And we are busy with a number of things and that are in the works to further expand testing. And we always have more than enough to do, and Toby has on our list to work on communication around serology tests and vaccines. So for more details about that, you can come in and ask questions, or you can wait on our potential communication in the future once it gets cleared.
Okay, great. Thank you so much.
Our next question is from Kim Snyder. Your line is open.
Hi, thank you. My question is around a clarification on the Biofire de novo, and just want to make sure I understood properly. Is that de novo now the predicate for all COVID NAT tests, or is it only for multiplex respiratory panel type testing COVID?
So I'll let Toby fill in any gaps here, but it's a predicate for all SARS tests. It can be used for full authorization comparisons, and it also can be used for EUA authorization comparisons. We're going to be open, continue to be open for other comparators to be used for EUA authorizations. As well as for full authorization, because there may be not full availability for everybody to get a limited number of fully authorized tests. Until we get to that point, once we get to that point where there's plenty of availability of fully authorized tests, we'll see what we do at that point.
Okay, thank you very much.
Yeah, and I would just add that until there are more 510Ks authorized for SARS-CoV-2, whether as a single analyte or a multi-analyte test, the Biofire is the only predicate for a 510K. But as Tim said, we do, we will consider other high sensitivity RT-PCR tests as the comparator for your clinical evaluation. But for the 510K, paper submission, the Biofire would be the predicate of record.
Yeah,
okay,
so
thank you.
A detail for those school and regulatory submissions about how you go about doing that. But you can, when you submit your 510K, you list a legally authorized predicate. That can't be a 510K otherwise. Thanks, Toby.
Our next question is from Kristen Bankard. Your line is open.
Hello, thank you for taking my call. I have a question regarding the serial testing, the asymptomatic post-authorization clinical study. Does the FDA have standard criteria for PPA and NPA specifically for molecular tests for that clinical study?
So, for molecular tests that in symptomatic populations, are above a 95% PPA in comparison to another EUA authorized test, we would expect that, that a once weekly serial testing program with a molecular test would yield a very high PPA, even in the asymptomatic population. Based on the recent data that has been, there's been a preprint out of a study that was sponsored by NIH and also other data that we have available. So we don't have a preset threshold for the asymptomatic screening performance because we just haven't seen enough data, and we haven't seen, other than this research study that was performed, we haven't seen, to my knowledge, a serial testing submission, so we could see what the data looked like. So once we get experience on what tests generally are able to achieve, and there may be differences between molecular and antigen tests, for example, because antigen tests are typically less sensitive than molecular tests. It was difficult to set an expectation. But obviously, we ideally would like to see all serial testing programs in both symptomatic and asymptomatic be above an 80% PPA if possible. But we're not setting a firm recommendation at this time.
Okay, thank you.
Our next question is from Emily. Your line is open.
Hi, my question is regarding the enrollment of individuals age 65 and older into a clinical evaluation trial for a molecular non-lab test. Our current protocol is written to exclude all individuals who have received a COVID vaccination, but in the guidelines, the target suggests a 35% enrollment of people who are 65 and older. Given that the large majority of these individuals have already received a vaccination, we plan to remove this exclusion from our trial. The question is, would the preference be to remove the vaccination exclusion for all subjects or just individuals over the age of 65?
So is this, for what type of test? Is this a serology test?
This is for a molecular test.
Molecular test. Toby, I'm not sure that I'm prepared to answer that question. Maybe we write it down and respond unless you feel you can handle that question today.
No, I think I would suggest that you send in your proposal with additional details about your proposed trial, and then we can respond specifically to your proposal.
And, I think we'll take this back and discuss and hopefully provide a definitive or clear answer next week on the call.
Okay, thank you.
Our next question is from Pachin Greg. Your line is open.
Hello? Can you hear me?
Yes, go ahead.
So I'm from XYZ Laboratories. We are in the process of validating the flu and the COVID combo or multiplex test. The question is, when we started, we were thinking it would be very easy to get the clinical samples with influenza A and B infection. The fact is, it's very difficult. And my question is it okay for us to use the inactivated virus of influenza A and B to make a contrived sample for the validation?
So if I just want to clarify, so you're looking to validate an EUA authorized, validate a panel test for EUA authorization, and you want to know if you can use contrived non-SARS respiratory viruses?
Contrived influenza A and B. So we are validating the multiplex test for the COVID and influenza A and B panel.
Yeah. Because there's already FDA cleared influenza tests on the market, we're wanting to make sure that performance of EUA panel tests that are new, that we haven't seen before for flu A and B, that they perform at an acceptable level, and we are asking for archive samples. This is sort of the first time I've heard that that archive samples are not available for flu A and B. You can always send an email with a pre-UA to a templates box, but until we know that that flu A and B banks are depleted for clinical samples, we would still like to see archive samples prior to EUA authorization, and then again, as we discussed, we would ask to see a prospective study post-authorization to be able to be considered for EUA authorization. So you explain your challenges in trying to obtain these archive samples. But again, this is an area where we've already cleared flu A and B, and they're available on the market, and so we're being cautious.
Okay, thank you.
Our next question is from Annie Wright. Your line is open.
Yes, hello. I had a question regarding the stability testing. For in the guidance, it describes stability testing to include transport and shipping. So I was just wondering, for the EUA, expectation of the FDA to also include some sort of worst case shake and bake scenario for the shipping and handling portion, or can we just basically have a shipping study that basically shows the transportation of a device without the actual simulated shaking and baking?
Toby, I'm not sure how much the templates go into details on this, but we are satisfied with an in-lab stability testing, looking at for EUA authorization, looking at temperature stability, and so we are now, since we can expect that this pandemic will go year-round, or the testing, at least for SARS, will go year-round going forward. We expect to see the potential extremes of heat, high temperature, and the extremes of frozen temperatures on shipping stability. Toby, do you have anything else to add on stability testing?
No, I'm also not completely sure how much detail is in the templates. I'd have to pull it up on that. But if you do have further questions beyond this, you can definitely send it in and we can take a look.
Yeah. So full authorization, we would potentially look at things like drops and things like that. But we've pulled that back for EUA, since the bar can be lower for EUA authorization. So I believe, but double check, that it's just the temperature extremes of shipping, and for the extreme potential extreme time for any return. We also ask for stability testing on any home collection device to make sure that once it enters into commerce, that it has an expiration date, and that we know what that is. And
for shelf life stability. Okay.
Yeah, accelerated stability for that is good for the initial authorization. We may, and then of course real-time stability after that.
So just really quick, for the extreme temperatures, are you expecting the data to be provided as part of the EUA submission, or can that just be like a protocol provided and then it could be like an ongoing study?
So for a home collection situation, we are asking to review that shipping stability study prior to authorization. If you were already using something for which we have authorized and there is a right of reference, such as the Gates collection study, you could potentially, if you use the sort of exact same things, you can potentially fall under that right of reference that Gates has offered. So you can ask about that in a submission, but you have a specific proprietary, unique device, then those stability studies would need to be repeated.
Okay, but do they need to be the data? These be submitted? EUA, or can it be part of like the real time data where you can say, okay, we're going to be doing this. This is what we're proposing to do.
No. Actual real time data. So I was talking about two different things. Real time is for the collection kit stability testing, not shipping.
Yeah.
And for that, we would want to see accelerated stability testing of your collection kit, and then we also want to see the shipping stability data to make the authorization and as part of the authorization recommendations for a home collection kit.
Okay. What about for professional use, point of care?
So for professional use, these are collection kits. If Toby, you're going to help me out on this, but if a kit makes a claim about use as a collection kit for SARS or SARS plus a panel, we would treat that as a device, and we would ask for, and obviously it would be shipped. And so we would look at the same sort of things there. Toby, did I get that right?
Right. If it's a proprietary collection device, we would expect to see information on the specific collection device, including some of the stability data. If you're simply using previously legally marketed standard nasal swab, things like that, then we're not likely to have additional questions.
Okay, thank you so much. Thank you.
Mm-hmm.
Our next question is from Shannon Clark. Your line is open.
Hello, this is Shannon Clark with UserWise Consulting. We specialize in human factors testing. Are you able to hear me?
Yes.
Yes. Oh, good. So with regards to the home use or non-laboratory use template for antigen and molecular testing, on our side, we've been getting feedback on our submissions in relation to the age range. And I just wanted to confirm that there is a typo in this template where under the clinical evaluation section number 8, it says the parent or legal guardian collects a sample from their child, e.g. age 3 to 13. And then just a couple paragraphs later, it says the study population should include individuals across all ages, 2 years to 65 plus years. Can you confirm that the age range you're looking for an OTC designation is in fact 2 to 65 years, and that the labeling shall specify that, or is 3 to 65 years adequate?
Yeah, thanks for pointing out a potential. Thanks for pointing out a potential typo here. The intended use population. We would like to see data for, if you want the full age range, is 2 to 65, I believe, not 3. And for self-collection in that population, we typically say age 14 and above can self-collect, and below that, parent, guardian, adults would collect.
And I did misspeak. It's 65 plus. Is there an upper age limit?
So, so what we want to see is that sort of age groups are included. So we'd like to see folks age 2 to 14, collected by parent, guardian, or adult, and then 14.
Mm-hmm.
Yeah, and then above 14 to above 65. We would like to see. Obviously, there's different potential issues in some groups. So I'd like to just see a good range. So include those who are 65 plus, and typically those who are enrolled and are age 14 to 65. You're going to typically, depending on how many enrollees you have in your study, you're going to see a good range in that. But I would make sure you got representatives of those below 14 and those above 65, and then you'll probably have plenty between the two.
Thank you.
Our next question is from Jackie Chen. Your line is open.
I have a question about the performance evaluation, in particular the emerging viral mutation monitoring plan. And my question is this expected for manufacturers who already have an EUA? And if so, can you share with us some examples on how they address and how these manufacturers monitor and deal with the new and emerging viral mutations for a serology or a neutralizing antibody test?
Okay, yeah. So it is something that we've asked all test developers, whether they've been EUA authorized or not, to have a monitoring plan in place. For those who are under review now or submitting in the future, we would want to see that plan. We're not asking manufacturers who have already been authorized to come back in with a plan submission, but to have a plan in place and to act upon it. But for those that are new submissions, we'll be asking about that for all assay types. And knowledge of your specific test is needed to address any potential issues. Molecular tests are relatively straightforward in that the sequences of primers and probes. You can do calculations around melting temperatures and know what your cycling parameters are or your isothermal parameters are, and determine with some modeling, simple modeling, whether or not your assay could potentially be affected. Serology tests are more challenging. We are all current serology tests under review. We are now asking for the antigen sequence that you're using, and we're logging that into our database. Obviously, it's an amino acid sequence. And so we would be scanning the nucleic acid sequence database for SARS for any amino acid changes within the antigen portion of the serology test. And we would ask developers to do the same. For antibody tests, for serology tests. For antigen tests, there's a different pathway. Developers would need to understand the characteristics of the antibodies that they use in their antigen test, and know the map of the antibody binding to the virus, and which is specific for every type of antibody that's monoclonal. Polyclonal will have different things to look for, but and then there it may depend on, in a polyclonal antibody, it may depend on what the antigen was used and the sequence of that antigen to raise the antibodies for that antigen test. So every test developer has some different things that they can do, and we're just asking that they come in with a plan. But it all starts with specific knowledge of your own test and examination of sequences in the U.S. Circulating sequence